In the first 24 hours of life, a newborn must pass meconium, a dark, viscous substance marking the first success of their digestive tract. If a day passes and this natural clearing fails to occur, clinicians immediately investigate for a structural blockage hidden deep within the infant's pelvic anatomy. During normal fetal development, the hindgut descends, while a lower indentation, the proctodeum, pushes upward. Ideally, these structures meet to create a single continuous channel. When this fusion fails, the child is born with an imperforate anus, leaving the digestive pathway physically obstructed. These clinical illustrations show the result. While the left panel displays normal male pelvic anatomy, the malformation on the right shows the rectum terminating blindly, with no anal opening. The critical landmark here is the pelvic floor, a muscular sling supporting the internal organs. By mapping exactly where the bowel stops relative to this muscular divide, surgeons can classify the case as either a low or high anomaly. In a low anomaly, the bowel successfully passes through the pelvic floor, but stops just millimeters short of the skin. These minor variations include a thin membrane blocking the exit, a bridge of skin covering the opening, a microscopic narrowing of the canal, or an opening that is simply shifted too far forward. Because the bowel has already crossed the pelvic floor boundary, the crucial sphincter muscles used for bowel control remain intact. These cases are minor developmental errors. They typically require only physical corrections, such as small incisions or regular dilations, rather than full internal reconstruction. Curious, but if the bowel is stopped high up and completely hidden inside the body, how do surgeons determine its exact location without operating? They use a technique called an invertogram. After several hours, gas naturally travels to the end of the rectum. The infant is then held upside down with a metal marker taped to the skin where the anus should be. On an X-ray, the buoyant gas rises to the dead end of the rectum, creating a distinct dark shadow. Surgeons then measure the distance between that gas pocket and the bright metallic marker on the skin. This measurement is definitive. If the gap between the gas shadow and the metal indicator is more than 2.5 centimeters, the defect is classified as a high anomaly. In high anomalies, the anal canal never forms, and the rectum terminates blindly above the level of the pelvic floor. Without a natural exit, the digestive system often forces open rogue pathways called fistulas. High anomalies in males often involve fistulas dumping waste directly into the bladder or urethra. The rarest female anomaly is the cloaca, shown bottom right, where the hindgut, bladder, and genital tract empty into a single shared cavity. A high anomaly is a complex anatomical failure. Correcting it requires surgeons to disconnect these rogue pathways and entirely reroute the pelvic structures. The definitive surgical solution for these cases is the abdomino-perineal pull-through operation. First, surgeons mobilize the trapped rectum, severing and sealing any fistulas. Next, they carve a precise pathway down the midline of the pelvic floor muscles. Finally, the rectum is pulled through this tunnel and sutured to the skin, creating a permanent, functional opening. Using the pelvic floor as a definitive anatomical coordinate allows surgeons to bridge the physical gap created during development. This surgical reconstruction resolves the life-threatening blockage, providing the newborn with a functional system and a path toward long-term health. When we hear the word benign in a medical context, we instinctively translate it to safe. We imagine a biological error that has resolved itself into something entirely harmless. But inside the dynamic, constantly regenerating environment of the lower gastrointestinal tract, that definition falls apart. In the rectum, a benign diagnosis simply means a growth is not yet cancer. It is a highly unstable status. This clinical image captures exactly what these anomalies look like in their dormant state. Against the healthy bowel wall, this smooth, pink mound appears deceptively innocuous. This presents a complex diagnostic challenge. When a gastroenterologist encounters a mass like this, they must determine if the growth is a static structural quirk or a precursor to invasive disease. The only way to accurately assess that danger is to map the tumor's exact location within the anatomical architecture of the rectum. We start at the mucosa, the surface lining of the rectum. This uppermost layer shares the same types of polyps found higher up in the colon. The lowest threat anomaly found here is the juvenile polyp. As the name suggests, it is highly prevalent in children, and it typically grows on the end of a long stalk, known as a pedicle. This diagram illustrates the straightforward mechanical solution for a juvenile polyp. Because of that long stalk, a surgeon can resolve the issue by tightening a loop around the pedicle, tying it off, and cutting the tumor away entirely. The medical math gets more complicated with the adenomatous polyp. Doctors continue to debate the exact statistical probability of these specific tumors turning malignant. Despite that debate, their mere presence demands immediate action. Surgeons navigate a sigmoscope, a lighted viewing tube, into the rectum, capture the fleshy mass with an electrified metallic snare, and cleanly sever it from the mucosal wall. The ultimate surface-level threat is the villous adenoma. Instead of a smooth mound, it grows into a massive frond-like structure that can expand until it completely fills the rectal cavity. A tumor this size causes systemic chaos. The villous adenoma secretes profuse amounts of thick mucus loaded with potassium, draining the patient's bodily fluids and triggering severe electrolyte imbalances. There is no debate about its biology. This tumor is a direct precursor to carcinoma. As its physical footprint increases, its tendency to mutate into lethal cancer rises in direct proportion. This schematic maps out the complex intervention required to defeat it: transanal endoscopic microsurgery. The process begins by inserting a scope and flooding the cavity with carbon dioxide. Inside this inflated workspace, surgeons use elongated instruments to meticulously excise the growth. Defeating these surface-level threats requires a linear escalation of technological intervention, scaling directly with the physical size and malignant potential of the growth. To find the next class of anomalies, we have to look deeper. We transition away from the surface lining and plunge into the submucosa, the deeper, fibrous tissue directly beneath. Here we find the benign lymphoma. Despite originating deep in the tissue, it pushes upward to present as a firm, pink to grayish nodule. It affects men and women of all ages equally and requires only a simple local excision. The endometrioma behaves entirely differently. This is a highly specific, systemic interloper that almost exclusively affects women between 20 and 40 years of age. This chart demonstrates the tumor's peculiar symptom profile. It creates constricting, bleeding lesions deep at the rectus-sigmoid junction, where the colon meets the rectum, with flare-ups linked entirely to her menstrual cycle. Because the tumor is driven by systemic biology, the surgical scalpel is often abandoned. Doctors instead prescribe ovulation-inhibiting pills, deploying hormones to force the physical lesion to biologically regress. The final deep tissue anomaly is the hemangioma. This is a rare vascular tumor located in the lower rectum. Because it compromises the blood vessels themselves, it causes severe bleeding, forcing surgeons to perform extensive excisions while carefully conserving the patient's sphincter muscles. Submucosal tumors are complex biological interlopers. They force doctors to discard standard mechanical removals and deploy radically different, origin-based treatment strategies. A diagnosis of a benign neoplasm in the lower GI tract is never a reason for inaction. It is a fleeting window of opportunity. Securing that window requires a vast spectrum of medical responses. It ranges from mechanically tying off a childhood polyp with a simple wire to deploying systemic hormonal suppression against a deep tissue endometrioma. Identifying the exact anatomical layer of the threat, whether it sits visibly on the surface mucosa or hides deep in the submucosa, determines which specialized procedure is required to neutralize it. Through precise topographical mapping and targeted intervention, clinicians eliminate precancerous threats before they transition to malignancy, preserving the natural function of the rectal wall.
Benign rectal tumors are non-cancerous growths from the rectal lining. You might feel fine until painless bleeding shows up on the toilet paper. They often start as polyps, tubular villous or tubulovillous adenomas, hyperplastic polyps, inflammatory hamartomatous polyps, and lipomas. Each has a different cancer risk. Some people get mucus discharge, constipation, altered bowel habits, or a feeling of incomplete emptying, and occasionally a polyp that prolapses. To see what's really there, the gold standard is colonoscopy. A scope passes through the rectum, and the mucosa appears moist with natural vascular markings. Your colorectal surgeon guides the camera, takes a biopsy, and may use CT or MRI for larger lesions. Most tumors can be removed during the procedure with snare polypectomy or endoscopic mucosal resection. Bigger ones may require transitional minimally invasive surgery or conventional surgery. Early detection and complete removal can prevent colorectal cancer. Screen early, remove early, prevent cancer.
If you found this video informative, please like and share, comment what you would like to see next, and subscribe to the channel to get notified about future informative videos.